My name is Laura Okoye,
And my name is Morgan Howard.
and we are second year Doctor of Pharmacy candidates here at Howard University.
Today we will be discussing a journal critique and review of an article entitled Improved Trial, a randomized controlled trial of patient-controlled analgesia, painful episodes, rationale, design challenges, initial experience, and recommendations for future studies.
Okay, so I'll begin with giving a brief overview of sickle cell disease as well as vascular occlusion crisis. Sickle cell disease is a form of anemia that is hereditary, and it can be characterized by single crescent-shaped red blood cells. It's predominantly seen in the African American community. The sickle red blood cells break down prematurely and obstruct circulation in the blood vessel. This deprives the vessels and the tissues with oxygen-rich blood. This leads to symptoms such as jaundice, fatigue, and painful episodes. Vaso-occlusive crisis, also known as sickle cell crisis, is characterized by an acute onset of severe pain. Typically, individuals suffering from sickle cell anemia will be rushed to the hospital when this happens, and they'll be treated with strong pain-relieving medications like morphine or even hydromorphone, for example. The improving pain management and outcomes with various strategies or improved trial was conducted to compare dosing patient-controlled analgesic strategies to manage vaso-occlusive crisis pain in order to implement the most effective dosing schedule for the patient. So this is our methods section. Individuals with all genotypes of sickle cell disease who were more than 10 years of age with vascular occlusive crisis with less than 12 hours of parental opioid therapy from time of presentation to the hospital and a pain score of greater than 45 millimeters on a 100 millimeter visual analog scale were eligible for the study. The independent variable in the study were the treatment options, and the dependent variable was the recorded number of pain on the analog scale. The study was designed as a randomized, single-blind, two-arm inpatient analgesics trial, and randomization was done separately for children who were 10 to 17 years old and for adults 18 and older. So in the first arm, that consisted of high demand, low infusion of hydromorphone or morphine, and the second arm consisted of low demand, high infusion of hydromorphone or morphine. The primary outcome measure was time to significant change in average daily pain intensity using a 100 millimeter horizontal analog scale.
Visual analog scales are psychometric measuring instruments designed to document the characteristics of disease-related symptom severity in individual patients, and this is used to achieve a rapid, statistically measurable and reproducible classification of symptom severity and disease control. Here are some examples of visual analog scales, which we will be referring to as VAS. 3 separate daily VAS were collected between 7 a.m. and 7 p.m. at least 4 hours apart. For each individual, their pain scale score was averaged, and these average scores were extrapolated into a longitudinal diagram for each patient to allow for an easy-to-read model of adjusted pain during VOC treatment. The diagrams were ordered by length of day, and the first occurrence of a 25 millimeter drop is represented by a solid black dot, whereas the first occurrence of a 45 millimeter drop is represented by a larger open circle. With this model, the median days to first drop and daily average VAS from baseline VAS was recorded and easily analyzed. For adults, those who had an average VAS drop in 35 millimeters and a p-value. For adults, those who had an average VAS drop of 35 millimeters on the VAS scale had a p-value of 0.067, and those with a drop of 45 millimeters had a p-value of 0.023, indicating statistical significance. For children, there was no statistically significant factors, and it is visibly clear that their pain management varied more drastically than adults. For study demographics, the opioid usage was analyzed in 22 adult participants and 12 pediatric participants. To avoid enrolling highly opioid tolerant participants, adult or pediatric patients were excluded who previously received moderate to high dose oral opioids. To avoid enrolling highly opioid tolerant participants, adult or pediatric patients were excluded who previously received moderate to high dose oral opioids equal analgesic to the initial opioid PCA dosing. And this was like methadone greater than 40 milligrams a day, sustained release morphine greater than 140 milligrams a day, or oxycodone treatment greater than 80 milligrams a day. Unfortunately, this decision resulted in a significant number of exclusions at some sites, which greatly impacted the study results. Of 1,116 individuals admitted for pain at 31 participating sites over a 6-month period, only 38 patients were randomized and 4 ended up withdrawing from the study. The trial was closed early due to limited clinic resources, poor communication, and poor study participation, reflecting a substantial number of challenges encountered during trial implementation.
There are major challenges for the study. To begin, there was so many different participating clinical sites that had a very diverse electronic medical records and diversified resources. The different resources or lack thereof affected pain management therapy. For instance, at one site, some patients received therapy that was much newer. Some clinics received therapy that used new infusion models, while others received therapy from older infusion models. Another issue is that there's a lack of ability to recruit a large sample size. The limited resources and staff available to participate in the study limited the study sample to only 38 patients. Speaking of the staff, many researchers present did not have adequate training, experience, or system access to develop the necessary order sets and had to rely on external clinical or informational technology staff to implement the protocol orders. This led to an interference with gathering data for analysis. So I will begin with the critiques. The strength of the study was that they were using a randomized control trial. Bias due to confounding was minimized and allowed for patients to start off at a similar baseline. This increases the internal validity of the study and prevents criticism of results being skewed because of other factors. For example, all patients were currently admitted to the hospital for pain management. If they were admitted for other conditions or symptoms that are qualified as less intense, but treated as other patients were, someone can say the reason the therapy is effective for lowering pain is due to the condition not being as severe as other patients. Speaking of baseline characteristics, the study unfortunately did not provide necessary demographic information for both arms. Although an age range was given, race, ethnicity, gender were not provided. The aforementioned characteristics are typically used to determine groups of the study and if they were similar to other treatments prior. And this can also reduce confounding bias. Another strength was that the patients were blinded for allocation. A single blind study is necessary because someone who has knowledge of what medication they are receiving may be less descriptive or even less honest with reporting their level of pain. Speaking of treatment, a weakness of the study was that they failed to have standard opioid dosing. Some patients were receiving therapy from newer and more effective technology, and also the clinics were using different body weight measures to calculate how much hydromorphone or morphine should be infused. Providing individual weight-based dosing for multiple dosing levels resulted in complex and potentially confusing dosing tables. Standard non-weight-based dosing schedules over a broad, critically appropriate range may be a more straightforward approach for future studies. This will in the future promote random error, which may only be eliminated with better funding, which will allow for more resources.
So this study had a high dropout rate. Remember when I was saying that the study went to sites which had about 1,116 patients admitted for pain. However, only 38 were randomized into the study arms. And so having smaller sample sizes prevents generalizing the study and of the study being representative of the larger population, which limits the possibility of having external validity. With small sample size, power of the study is also very poor. Next, we'll be discussing the conclusions, implications, and future directions.
So now I would like to conclude with the conclusion, implications, and future directions. The trial was unfortunately terminated early. This was mainly because there was countless challenges conducting clinical trials in the inpatient setting. This was because there was multiple care providers and varying electronic medical records. The primary outcome of the study, which was to find the time to experience a painful crisis from vaso-occlusive event, was also very broad and needed more explanation to clearly display the purpose of the study. Because the study evaluated patients who were admitted into the hospital, most patients were already experiencing an event and received analgesics, so they really could not give an evaluation or a clear answer if they were experiencing new pain or if the treatment was actually working and providing pain relief. These experiences may help researchers create a better study design in the future to help with therapeutic regimen improvements for pain management. This study has set the framework for what is needed to conduct a clinical trial associated with sickle cell disease and vaso-occlusive crisis. It will be very, very valuable if others wish to conduct a similar study in the future.
This concludes our discussion on sickle cell disease and pain management therapies and the journal review article. We would like to thank Dr. LaMarcus Wingate for offering this course at Howard University College of Pharmacy and for allowing us to experience this great project